Chapter 9 from Rao's Respiratory Care Pharmacology. Mucus controlling drug therapy. Drug control of mucus, a perspective. The mucociliary escalator is the major defense system for the lung. Failure of this system may result in mechanical obstruction of the airway with thick and sticky secretions. Properties of mucus include there being protective, that mucus lubricates, it provides waterproofing, and it also traps bacteria, viruses, and other microorganisms. Clinical indications for use of mucoactive agents include to reduce accumulation of airway secretions, improve pulmonary function and gas exchange, and prevent repeated infection and airway damage. Some respiratory diseases that can benefit from mucoactive treatment include cystic fibrosis, chronic bronchitis, pneumonia, diffuse panbronchiolitis, primary ciliary dyskinesia, asthma, bronchiectasis, and some neuromuscular diseases. Things to consider after mucoactive therapy. Therapy to decrease infection or inflammation, and removal of irritants, including tobacco smoke. Tobacco cessation may be needed. Let's identify some of the mucoactive agents that are used in respiratory care. N-acetylcysteine or NAC, Dornase alpha, and aqueous solutions such as water saline, hyperosmolar saline are all used in respiratory care. How does the mucociliary escalator work? The source of airway secretions are found in the surface of the airway. The secretions lining the surface of the airway are called mucus, and they've been described as having two phases. A gel layer, which is 0.5 to 20 microns, is propelled towards the larynx by the cilia and lies atop a weak gel layer about the height of a fully extended cilium. Cells responsible for secretion in the airway and the source components found in respiratory mucus are surface epithelial cells, pseudostratified columnar ciliated epithelial cells in particular, surface goblet cells, and Clara cells in the distal airway. There are also submucosal glands with serous and mucous cells. Submucosal glands are found in the cartilaginous airways. These mucus-producing glands are not found beyond the distal airways. Mucus is secreted by surface epithelial cells and glands into the airway and provides for basic protection of the respiratory tract, including humidification and warming of inspired gas, mucociliary transport of debris, waterproofing and insulation, and antibacterial activity. So let's take a closer look. Here you can see the gel phase and salt phase. You can see the cilia waving, the pseudocolumnar epithelium, mucus cells in a submucosal gland, the sympathetic efferent and parasympathetic nerves going to the spinal cords, afferent C fibers, the surface goblet cells. Bronchial smooth muscle is also noted. So let's talk about some terminology. Let's define some of these terms. A mucoactive agent is any medication or drug that have an effect on mucus secretion. These can include mucolytic, expectorants, mucospicific, mucoregulatory, or mucokinetic agents. What is a mucokinetic agent? A mucokinetic agent is a medication that increases cough or ciliary clearance of respiratory secretions. A mucoregulatory agent are drugs that reduce the volume of airway mucus secretion and appear to be especially effective in hypersecretory states when they have a lot of mucus, like bronchorrhea, diffuse panbronchiolitis, and some forms of asthma. Mucospecific. These are medications that increase the viscosity of the secretions and may be effective in therapy of bronchorrhea. A mucolytic agent. Most of these medications are thought to mobilize secretions by mechanisms other than direct thinning of the mucus. They break disulfide bonds or break down proteinaceous things in the secretions. The surface of a healthy trachea includes ciliated and goblet cells at a ratio of approximately 5:1. There are more than 6,000 goblet cells per square millimeter of normal airway mucosa. Goblet cells do not seem to be directly innervated in the human lung. They do respond to irritants and other inflammatory mediators. Submucosal glands below the epithelial surface are thought to provide much of the mucin on the airway surface. The submucosal gland is under parasympathetic or vagal control. It responds to cholinergic stimulation by increasing the amount of mucus secreted. Evidence suggests that the submucosal glands in the respiratory tract are innervated by sympathetic axons and peptidergic nerve system. Droplets of mucus from secretory cells form plaque in the distal non-ciliated airway, and these coalesce into a continuous layer in the more proximal ciliated airway. Mucociliary transport results from the movement of the mucus gel by the beating cilia in the sol layer. There are approximately 200 cilia on each ciliated cell. Cilia are about 7 microns in length in larger airways and shorten to about 5 microns or less in smaller bronchioles. Cilia beat in a coordinated way. They have a wave of motion to propel airway secretions up and out. A functional surfactant layer lies at the tips of the cilia and separates the periciliary fluid from the mucus gel. This layer allows the cilia to transmit kinetic energy effectively to the mucus without becoming tangled up. This layer also facilitates mucus spreading in a continuous layer and prevents water loss to the sol layer. So you can see foreign particles stuck to the top of the gel layer. the cilia underneath in the sol layer beating, and those are going to move up and out. Factors that slow the mucociliary transport include chronic obstructive pulmonary disease, cystic fibrosis, airway drying, such as with use of dry gas in mechanical ventilation, narcotics, and endotracheal suctioning. Other factors that affect mucociliary transport include airway trauma, tracheostomy, cigarette smoke, atmospheric pollutants, and hyperoxia and hypoxia. Food intake and mucus production. A common belief is that drinking dairy products increases the production of mucus and congestion in the respiratory tract. Respiratory care personnel may be asked for advice on withholding milk from children with colds, respiratory infections, or chronic respiratory conditions such as cystic fibrosis. However, in a study of 60 healthy subjects with experimentally induced rhinovirus respiratory infections, milk intake ranged from 0 to 11 glasses a day. There was no association between milk or dairy product intake and respiratory tract symptoms of congestion or nasal secretion. None of the subjects were allergic to cow's milk. The investigators concluded that the data did not support the withholding of milk or the belief that milk increases respiratory tract congestion. So let's talk a little bit more about mucus. A healthy person is thought to produce about 100 ml of mucus every day. That's about enough to fill the palm of your hand if it's cupped. These are clear, visoelastic, sticky secretions. Most individuals never notice that they produce or swallow these secretions. However, in the case of disease, the volume of secretions can increase dramatically, and secretion clearance can be diminished so that secretions cannot be expectorated or swallowed. A primary function of the respiratory tract mucus is thought to be transporting and removing trapped particles, cellular debris, and dead and aging cells. Here is the basic structure and constituents of a mucus macromolecule. You can see mucigens, serine, threonine, N-acetylhexosamine, and a glycosidic bond. Here you can see disulfide bonds. That's what makes mucus rubbery. Under normal conditions, the composition and volume of the sol layer is regulated in part by ion transport across the epithelial cells lining the airway lumen. If the sol layer is not approximately the height of an extended cilium, mucus movement is less effective. In the basal unstimulated states, the sodium ion absorption in the epithelial cell is the dominant ion exchange that absorbs liquid from the airway sol layer. Sodium absorption occurs as an active transport process through sodium channels on the apical or airway side of the cell. Sodium in the epithelial cell is pumped in from the cell driven by a sodium-potassium adenosine triphosphate or ATPase pump on the basolateral membrane of the epithelial cell. This illustration is of the ion exchange mechanisms across a normal airway epithelium, controlling absorption and secretion of the periciliary airway surface liquid, or ASL. We also call this the sol layer. Under basal conditions, sodium is absorbed along with liquid with no net chloride secretion from the cell into the liquid layer, or sol layer. CAMP, cyclic adenosine 3,5 monophosphate, CFTR, cystic fibrosis transmembrane ion conductance regulator, are all found here. Mucus in disease states. Let's start with chronic bronchitis. Chronic bronchitis is defined clinically as daily sputum expectoration for 3 months of the year for at least 2 consecutive years, usually in a tobacco smoker or an ex-smoker. In the airway of a subject with chronic bronchitis, there is hyperplasia of submucosal glands and goblet cells. The number of goblet cells increases, and there is hypertrophy of the submucosal glands as measured by the Reed index of gland-to-airway wall thickness ratio. It has been reported that chronic sputum expectoration is associated with a more rapid decline in lung function, and for persons with COPD, more frequent admissions to the hospital. Let's talk a little bit about asthma. In acute, severe, and fatal asthma, there is profound hypersecretion of highly viscous and rigid mucus. This leads to complete airway obstruction. Because most of these patients have received large amounts of beta agonist bronchodilators, sometimes even by the IV route, it is likely that the beta receptors are fully saturated. Beta agonists may induce the secretion of viscous mucus and may contribute to airway obstruction. What is bronchorrhea? Bronchorrhea is defined as the production of large volumes of watery sputum. This occurs in about 9% of adults with chronic asthma. Some of these patients respond well to anti-inflammatory agents such as corticosteroids, anticholinergic medications, or antibiotics. Plastic bronchitis. Plastic bronchitis is a rare disease characterized by the formation of large gelatinous or rigid branching airway casts. This is dramatically different from the mucus or sputum plugs expectorated by patients with purulent pussy airway diseases like CF, cystic fibrosis. Plastic bronchitis has not been shown to occur as a result of CF. Casts are often too thick to be easily suctioned through a bronchoscope and too friable to be grasped and removed with forceps, so freezing and cryoprobe extraction is usually performed at bronchoscopy. Cystic fibrosis. Cystic fibrosis is a hereditary disease characterized by the impaired function of the CFTR protein. There is chronic airway infection, often with Pseudomonas and other gram-negative organisms, which we'll talk more about in anti-infectives. Although there may be mucus hypersecretion in CF, it is not known that with established CF bronchiectasis, the airway secretions contain very little intact mucin, and obstruction appears to be caused by DNA actin polymers, or proteins. The airways in CF are almost entirely filled with pus derived from neutrophil degradation and neutrophil extracellular traps. The decrease in mucin in CF sputum may be related to chronic bacterial infection by Pseudomonas and breakdown of mucigens by proteinase derived from neutrophils or bacteria. Physical properties of mucus. Physical properties of mucus include viscosity, elasticity, cohesivity, and adhesivity. Let's talk a little bit about the adhesive forces. Adhesion is the ability of unlike objects to attract each other and stick together, like mucus and the airway surface. In the airway, adhesive forces refer to the attractive forces between mucus and the airway surface. Adhesion reduces the ability to clear secretions through coughing. Mucokinetic agents are either adhesives, such as surfactant, which reduces the adhesivity of secretions, or agents that increase the power of airflow and cough. Mucolytics may work in part by severing the bonds of mucus to the epithelium and reducing friction or adhesion. Cohesive forces or attraction between like molecules. Spinability is the ability of mucus to be drawn out into threads. It was the property of spinability of the respiratory mucus was subsequently identified by Purcell. They used a device to stretch mucus vertically at a constant rate and measured the spinability of a mucus thread as the maximal length to which the thread could be drawn before it broke. Rheology is the study of deformation and flow of matter. Viscosity is defined as resistance of fluid to flow, and elasticity is the ability to snap back, or the ability of a stretched out material to return to its original shape. This shows the difference between viscosity and elasticity. Viscosity is resistance to flow. Elasticity is snapping back into shape after it's been stretched out. Mucus as a viscoelastic material. The mucus gel is a viscoelastic material and responds to an applied stress as a fluid and as a solid. As a solid, a gel has elastic deformation, storing energy with applied force, ciliary beating. And as a liquid, a gel flows under applied force. As the tips of the cilia contact the gel during the forward power stroke, the gel is stretched, and its elastic recovery causes it to snap forward. At the same time, the mucus gel flows forward as a liquid under the forward beat of the cilia. This is an illustration of the viscous and elastic properties affecting the movement of viscoelastic substances, such as unvulcanized rubber and mucus. Spinability or cohesivity of mucus is the ability of mucus to be drawn out into threads, like the little boogers on this child that you see here. It gives information about the internal cohesive forces of mucus. Evaluation of mucus properties is complicated by the fact that mucus exhibits non-Newtonian rheology. A non-Newtonian gel, such as mucus, has changing viscosity with varying applied force, or shear force. As the shear rate increases, the apparent viscosity of mucus usually decreases. However, some mucus exhibits a sudden collapse of viscous behavior at high applied stress. This is called apparent yield stress. Sputum that yields may be more easily cleared by a cough. These changes in viscosity are consistent with rupture or change in the macromolecular chains and cross-linking network of the gel. Because of its non-Newtonian behavior, evaluation of the properties of mucus and of the effects of drugs on those properties is complicated and must be performed under standardized conditions. Mucolytic agents decrease the elasticity and viscosity of mucus. Because elasticity is crucial for mucociliary transport, mucolytics have the potential for a negative effect on normal physiologic mucus clearance. Reduction of mucus gel to a more liquid state may facilitate aspiration of secretions with the use of suction catheters. The status of mucolytic agents in pulmonary disease has been reviewed at several conferences on the scientific basis of respiratory care. Therapeutic options for controlling mucus hypersecretion are as follows. Remove causative factors where possible. Treat infections. Avoid all tobacco smoke exposure. Avoid pollution and allergens. Improve tracheal bronchial clearance. Use bronchodilators if these are available to increase expiratory airflow like in asthma. Use bronchial hygiene measures, cough, deep breathing, chest physiotherapy, and oscillating PEP therapy. Improve airflow by exercise and nutritional rehab. Use mucoactive agents as indicated. Classic mucolytics reduce mucogens by severing disulfide bonds. Let's start with talking about N-acetylcysteine, or NAC. As a mucolytic, NAC has been used in conditions associated with secretions of viscous or rubbery mucus. A second use of NAC is as an antioxidant antidote to reduce liver injury, like with acetaminophen overdose or Tylenol overdose. It can be given for that. NAC disrupts the structure of the mucus polymer by substituting free sulfhydryl groups for the disulfide bonds. It breaks disulfide bonds. Some of the hazards associated with NAC are bronchospasm when using a 20% solution and mechanical obstruction of the airway. It's incompatible with antibiotics in mixture, and so it must be given in a separate nebulizer. Let's talk about Dornase alpha, or Pulmazine. It's indicated for use in CF patients or anywhere there are pussy purulent secretions. It is used to reduce the frequency of respiratory infections requiring IV antibiotics, and it improves or preserves pulmonary function in CF patients or those with pussy, thick, proteinaceous secretions. It works when given by aerosol by reducing the viscosity and the adhesion by breaking down the proteins or DNA in the mucus. It's available in a single-use ampule with 2.5 milligrams of drug in 2.5 mils of clear colorless solution. It should be refrigerated and protected from light. The usual dose is 2.5 milligrams daily, delivered by an approved nebulizer, such as the Acorn 2 nebulizer, the Perry LC Plus nebulizer, or the Hudson RCI Updraft 2 OptiNeb. Adverse effects of Pulmazine include that there's little difference between Dornase alpha 3% and placebo 2%. Common side effects include voice alteration, pharyngitis, laryngitis, rash, chest pain, and conjunctivitis. Clinical application and evaluation is based not only on lung function, but also reduction in the number and severity of infectious exacerbations and the need for IV antibiotics and hospitalization. Let's talk about gelsilin and thymosin. These are F-actin depolarizing drugs. Gelsilin 8,5-KDA is an actin-severine peptide. It has been shown to reduce the viscosity of CF sputum in a dose-dependent manner. Thymosin B4 decreases sputum cohesively in a dose-dependent and time-dependent manner. In vitro studies have shown that the F-actin depolarizing agents, along with Dornase alpha, result in a greater reduction in sputum cohesivity and vasoelasticity than either agent alone. Expectorants. Potassium iodide and glycogluconate are considered expectorants rather than mucolytics, but these drugs have not been shown to be effective when treating acute or chronic airway disease. Sodium bicarbonate 2% is a base that has occasionally been used for direct tracheal irrigation or as an aerosol. The inflammation caused by bicarbonate is thought to draw water into secretions, but this has not been demonstrated clinically. Its use cannot be recommended. Guaifenesin is usually considered an expectorant rather than a mucolytic. It can be ciliotoxic when applied directly to the respiratory epithelium. It is thought that the expectorant action of guaifenesin is mediated by stimulation of the gastrointestinal tract and not by systemic exposure to the drug. Guaifenesin has been approved as an expectorant by the FDA in a bilayer extended-release tablet, like Mucinex. Mucokinetic agents. Mucokinetic agents increase cough clearance by increasing expiratory flow or by reducing sputum adhesivity and tenacity. Bronchodilators may increase ciliary beating but has little effect on moving secretions. Beta agonists can also have increase expiratory flow in individuals with an asthmatic component of airway disease and may help to get rid of secretion. Surfactant, or a surface active phospholipid, is produced in the conducting airways and in the alveoli and is important for mucociliary and cough clearance. It prevents airway dehydration, permits mucus spreading on extrusion from the glands, allows efficient ciliary coupling with mucus, and more importantly, allows ciliary release from mucus once kinetic energy is transmitted. Surfactant therapy has been shown to be effective in treating chronic bronchitis and cystic fibrosis. Mucoregulatory medications decrease mucus hypersecretions. These include steroids, anticholinergics like tiotropium, ipratropium bromide, and atropine, Robenal, and macrolide antibiotics. Antiproteinases. Patients with CF have increased activity of serine proteinase on the respiratory epithelial surface. Neutrophils, when activated or degenerating, release protease, such as elastase, that can be directly damaging to the epithelial cells and impair airway clearance. Neutrophil protease causes a secretory response from the submucosal glands with an increase in mucus production. This alpha-1 antitrypsin can be given IV or by inhalation. It is a recombinant secretory leukocyte proteinase inhibitor. 7% saline has been used for years as an irritant to induce cough. Hypertonic saline, or 7% saline, can improve mucociliary transport and lung function, and it's thought to largely result from the acute effects of inducing cough and hydrating airway surface with fluid. The most common problems are unpleasant taste, and coughing may make it unsuitable for long-term use. In some studies, it has been shown to decrease FEV1. It's available in single vial for use. Gene therapy. Gene transfer therapy presents a novel use for aerosols. Effects of this arena have been centered largely on complementary DNA transfer of normal CFTR genes in patients with cystic fibrosis. Gene transfer was first attempted by inserting the normal CFTR gene into a replication defective adenovirus vector by bolus bronchoscopic delivery of the vector. An unanticipated host immune response to the vector led to reevaluation of this strategy. For gene transfer to be effective, the vector and its package must be non-immunogenic, stable to shear forces during aerosolization, and safe for transfected cells. The vector should not increase cell turnover. It should stably integrate into the polygenitor or basal cell genome and be safe and effective for repeated administration. Viral vectors that have been studied are adenoviruses, adeno-associated virus, and lentivirus. Gravity. Many physical factors affect secretion clearance. Gravity is not a primary mechanism alone for normal mucociliary transport. However, postural drainage may show benefit when incorporated into conventional chest physiotherapy, or CPT. Insufflation-exsufflation devices inflate lungs with positive pressure followed by a negative pressure to stimulate a cough. The cycle begins with an inspiratory pressure of 25 to 35 centimeters of water for 1 to 2 seconds, followed by an expiratory pressure of negative 30 to 40 centimeters of water pressure for 1 to 2 seconds. The primary application for this is in patients with neurological neuromuscular weakness. Shown here is an insufflation-exsufflation device. Active cycle of breathing, or ACB, and forced expiratory technique, or FET maneuver, is a combination of breathing control, relaxed diaphragmatic breathing, thoracic expansion control, or deep breaths, and forced expiration technique from progressively increasing lung volumes. There are no documented studies showing benefit. Autogenic drainage aims to optimize airflow in various generations of bronchi to move secretions. This technique incorporates staged breathing, starting with small tidal breaths from expiratory reserve volume and repeating until secretions collect in the central airways. Patients are instructed to suppress cough. A larger volume of air is taken for a series of 10 to 20 breaths, followed by a series of even larger breaths, and then followed by several huff coughs. This technique requires a great deal of patient cooperation and is used only for patients older than 8 years old and patients who have a good sense of their own breathing. It can be difficult to teach and administer. Exercise. Exercise causes increased sputum production compared with rest. It appears to augment bronchial hygiene maneuvers. Patients that can walk should be encouraged to walk. Using mucoactive therapy with physiotherapy and airway clearance devices. Positive airway pressure techniques can be effective alternatives to chest physiotherapy in expanding lungs and mobilizing secretions. These include pursed-lip breathing, cough, FET. Use of oscillating PEP therapy, such as a flutter or a cappella or percussinator, can be highly effective in mobilizing secretions. The vest is reported to be effective for secretion clearance in patients with CF. It is thought that this device has a role in lung expansions for patients other than those with cystic fibrosis in acute care settings. So you may see it used not only with a CF patient like pictured here, but in the acute care hospital. What does the future bring? Thicker, denser strands of mucus may be moved more efficiently by ciliary contact and elastic recovery than with thin, low viscosity solutions. Endotracheal aspiration of secretions using suction would be easier with low viscosity mucus. Treatment of bronchial hypersecretion would be better aimed at normalizing the rheological properties of mucus to optimize transport. Using mucospecific agents. Before treatment, assess a patient's adequacy of cough and level of consciousness to determine the need for mechanical suctioning or the need for adjunct bronchial hygiene or airway clearance devices. During treatment and in the short term, instruct and verify correct use of aerosolized nebulizer system, including cleaning and maintenance of the nebulizer. Assess therapy based on the indication for drug or device, monitor airflow changes, such as a decrease in FEV1, and assess breathing patterns and rate. Assess the patient's subjective reaction to treatment, whether breathing effort or pattern changes, and discontinue therapy if the patient experiences any adverse reactions. Long-term, monitor number and severity of respiratory tract infections and need for antibiotic therapy, emergency visits, and hospitalizations. Monitor pulmonary function for improvement or slowing of the rate of deterioration. General complications can be seen in some cases. If the FEV1 is less than 25% of predicted, it becomes difficult to mobilize and expectorate secretions. Use of mucoactive therapy with caution in patients with severely compromised vital capacity and expiratory flow, such as end-stage pulmonary disease or in neuromuscular disorders. Gastroesophageal reflux and the inability of a patient to protect their airway are risk factors for postural drainage. Caution should be used. Mucoactive agents should be discontinued if there is evidence of clinical deterioration, and patients with acute bronchitis or exacerbation of chronic diseases like cystic fibrosis and COPD may be less responsive to mucoactive therapy, possibly because of infection and muscular weakness. Thank you for listening to mucoactive agents. This is the end of our presentation.